The appropriate staging for gastric and GE junction cancers begins with a physical examination and basic blood work. You need an endoscopy to establish the mass in the upper GI tract and get tissue to make a diagnosis. You need a CAT scan to evaluate the extent of the disease. And that's actually my typical sort of starting pattern is an endoscopy and CAT scan. If the CAT scan is negative and it's not obvious on the CAT scan if there's nodal disease or gastric wall thickening, then I would proceed with an endoscopic ultrasound because that can help differentiate early stage versus locally advanced disease. If patients have early stage disease, then often you might be able to go straight to surgery. If it's locally advanced, you would consider perioperative therapy. But if the CAT scan shows metastatic disease, then I often do perform a biopsy to confirm metastatic disease, primarily because this diagnosis of metastatic gastric cancer is life-changing. It's a terminal illness, unfortunately. For patients who don't have metastatic disease, we often perform a laparoscopy because occult metastatic disease in the peritoneum happens in about 30% of patients. So patients with locally advanced disease based on imaging and endoscopic ultrasound should have a laparoscopy prior to embarking on treatment for locally advanced disease. Yeah, so molecular testing is evolving in gastric and GE junction cancers. Just 5 years ago was the first time that we actually got a targeted agent approved, and that was HER2, trastuzumab for HER2 positive disease. And since then, we have two additional targeted agents that are approved, and they require testing for 2 additional testing. So the additional testing that should be done includes PD-L1 testing for which if you're positive, then in the third line setting you can receive pembrolizumab, and mismatch repair deficient testing, which is for pembrolizumab in the second line setting for tumors that are mismatch repair deficient. So our standard panel does include those 3. So we do test for HER2 overexpression by IHC or FISH. We test for mismatch repair deficiency, and we also test for PD-L1 expression based on the combined positive score. Most places have a panel, and so do we at Weill Cornell. And so this is a pretty comprehensive panel that looks at other features like RAS mutations or CDH1 or PIK3CA, things like that. But right now they don't have clinical significance, at least in gastric and GE junction cancers.